Everyone, and welcome to the Melanoma Research Foundation Ask the Expert series. My name is Debbie Churgai. I am the Senior Education Program Manager at the Melanoma Research Foundation. We are pleased to have you join us today for this wonderful educational opportunity entitled Minimal Residual Disease Testing and Melanoma Management. Today, we will be discussing MRD testing and why it's an important option in the treatment of melanoma. During the webinar, we will explore what MRD testing is, what types of testings are available, and how experts can integrate MRD testing into melanoma treatment and patient care, explained in a way for patients to feel empowered and educated. And please stay at the end because you'll have the opportunity to ask questions live. First, I want to thank our sponsor, Haystack MRD by Quest Diagnostics. We are grateful to them for their generous support of this webinar and investment in the MRF's mission in helping to educate and provide support to the patient community at large. Before we get started, I just want to share a little bit about the MRF. The Melanoma Research Foundation is the largest independent organization devoted to melanoma. Our mission is to eradicate melanoma by accelerating medical research while educating and advocating for the melanoma community. The MRF is committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. At the MRF, we know that education is critical for patients to make informed decisions about their care. We have many educational programs and offerings, and they are not only directed at patients, but we create educational materials and events for caregivers, family members, and providers. Our educational literature is all free to download or order on our website. You can order materials for health fairs, schools, conferences. We also send these materials to physician offices, cancer and health centers all over the US. Oops, sorry. We have 6 animated patient videos and 3 more currently in production. These videos are all less than 10 minutes long and pack in a lot of information with great visual images. If you have family or friends who want to learn more about melanoma, these are a great educational option to send to them. Each year, the MRF hosts a series of in-person educational events in partnership with major academic medical centers. These meetings provide an opportunity to learn from leaders in melanoma and network with other patients and caregivers. We just completed 4 symposia earlier this year, which you can go back and watch them at any time. You can find those links under the events tab on our website, or you can watch them on our YouTube channel. We have 2 more that are coming up in the fall. So if you live near Santa Monica, California, or Houston, Texas, please keep an eye out for more information on those soon. Not only are past symposia available on our YouTube channel, but we also have dozens of other educational offerings available, including our Ask the Expert webinar series like tonight, and our melanoma educator courses. We also have a variety of patient and caregiver support services, such as our Patient and Community Forum, Treatment Center Finder, Financial Assistant Resources, and our Ask the Nurse hotline. The MRF is proud to partner with CareBox for our Clinical Trial Finder. The Melanoma Clinical Trial Finder is an invaluable tool that connects patients with the trials tailored to their specific diagnosis, ensuring they receive the most up-to-date options available. You can find this information on our website underneath the Patient Care tab, and you can even request a navigator to talk to you through the process. Advocacy is the MRF's second pillar, empowering patients and caregivers to make their voices heard. Every year, we bring members of our community to Capitol Hill to meet with congressional leaders and advocate for increased cancer research funding, specifically melanoma. And save the date for March 1st through 3rd, 2026. That's our next advocacy day. And reach out to education@melanoma.org if you'd like to join. Research is at the heart of our mission, supporting scientists whose discoveries lead to better treatments, improved outcomes, and new hope for melanoma patients. So this slide highlights some of our groundbreaking research the MRF has funded in the past and continues to support today. There are many opportunities to support the work of the MRF through a variety of programs, events, and research funding. We host events such as patient symposia, Miles for Melanoma 5Ks in cities all across the country, and we hope you will join us at one of these amazing events. If you would like to know more about the resources and events I've discussed today, please scan the QR code below and you can receive our newsletters and learn about our ongoing efforts to eradicate melanoma. Give it a second. And if anyone wants to scan it. Lastly, the best way to learn about more about anything that I talked about today, including our education, advocacy, or research programs, awareness campaigns, and upcoming events, is to follow us on social media. Oops. And I just want to thank our sponsor, Haystack MRD, for their generous support one more time. Okay, so now we are going to start just a little bit of house cleaning before we get started. We encourage you to use the Q&A box. It's usually at the bottom of the screen to ask questions throughout the session. The information presented, we'll ask the questions during the end of the Q&A. The information presented during today's session is for educational purposes, and any individual treatment option questions should be directed to your healthcare provider. We encourage everyone to visit melanoma.org to learn more about the resources we have available. All right, we're going to get started first. I would like to introduce Dr. Slavin from Haystack MRD by Quest Diagnostics. Dr. Slavin is a physician scientist and biotech executive, triple board certified in clinical genetics, molecular diagnostics, and pediatrics. He is Chief Clinical Officer of Molecular Oncology at Quest Diagnostics. He previously held the positions of Chief Medical Officer at Myriad Genetics and Chief Scientific Officer at Halo Precision Diagnostics. He was a former assistant professor in the departments of medical oncology and population sciences at City of Hope National Medical Center. Dr. Slavin graduated from the University of South Florida Medical School with honors. He completed his residency programs at Case Western Reserve in Cleveland, Ohio. This training also included a postdoctorate research year in genetic epidemiology. Dr. Slavin is an active faculty member of City of Hope Hereditary Genomics Training Program. He is a well-respected researcher in the field of medical genetics, publishing over 80 journal articles, collectively evaluating genomic data from over 500,000 patients, multiple book chapters, and providing numerous presentations at national and international medical meetings. Dr. Slavin, we're happy to have you here today.
Yeah, thanks, Debbie. I get to work with a lot of really amazing people and to meet a lot of really amazing people in my life. And, sometimes you come across people that, really make you feel lazy in life. And Dr. Beitsch is one of those people for me. So, when I see all the things, the great things that he's doing, is really amazing. So we're so privileged to have him here. So thank you for coming on. So, for those that don't know, Dr. Peter Beitsch, he's a surgical oncologist. He trained at MD Anderson and John Wayne Cancer Institute. And over the last 30 years, he's contributed to multiple practice-changing articles and studies, sentinel lymph node biopsy, breast radiation, genomic testing, breast cancer genetics. In addition to all this amazing work, he's built and led innovative ventures on the business side, including founding North Point Cancer Center, establishing Targeted Medical Education, which is a great group, serving as a scientific officer at MedNeon, which was then acquired by Invitae. And he also just recently, he's a lifelong learner. He just recently completed the Emory Chief Medical Officer program to strengthen his expertise in clinical care research and executive leadership. So, so privileged to have you here, Peter. Thank you so much for coming on. Really appreciate it.
Well,
Take it away.
Thanks for those very kind words. And Debbie, thank you and the Melanoma Research Foundation for asking me to speak today. A topic that's really near and dear to my heart. This is the future of melanoma care, probably all cancer care. And so I think this will be an educational evening. I didn't know the sort of the baseline educational level on genetics with everybody in the audience, so I started fairly basic, but I think it'll be interesting. So without further ado, let me share my screen and we will get rolling here. There we go. Can everybody see that? Circulating tumor
Yes, we
DNA,
can.
minimal residual. Okay, good. All right, we'll get rolling. All right. There we go. So human DNA. So we all have 23 pairs of chromosome in every cell in our body. Think about that for a minute. That's a lot. Billions and billions of cells, 23 pair, one from your father, one from your mother. So 46 in each cell. Women have two X's, men have an X and a Y. The chromosomes, the DNA is actually made up of base pairs, adenosine and thymine, AT, and cytosine and guanine, CG, are the base pairs. There's 3.1 billion base pairs in the 23 chromosomes. So you have 6.2 billion base pairs in every cell in your body. There are minor variations in that DNA. And it's a lot of variations. Once I sort of started to get into genomics and genetics, there's a minor variation every 300 base pairs. So there are 10 million minor variations in everyone's genome. That's an amazing number to me. So we're all the same, but we're all slightly different. And these slight variations, most of the time, they are single nucleotide variants. They're just changes in the base pairs. Most of them are completely innocuous. They're in unimportant regions of your DNA. Some actually improve protein function, and that may be how evolution occurs. And then some mutations, changes, cause protein dysfunction, and we'll talk a little bit about that. So if you look at the whole genome, there's about 20,000 protein coding genes. Proteins are what make the cells go. All the structure of the cell, the things that the engine of the cell are on the surface, cell surface, inside the nucleus, outside the nucleus. Those are all generally proteins. And the protein coding genes are only about 2% of the genome. So 98% of the genome is just regulatory. There are these pseudogenes we really don't know that much about. Maybe Dr. Slavin can tell us. They're repetitive sequences. There's a lot of stuff in our entire DNA genome that we know a lot about, but not everything about. From the DNA in your nucleus, messenger RNA is eventually made. The DNA has a promoter region. There are introns and exons in each gene. That intron exon are made into RNA, and then the introns are cut out. The exons make messenger RNA, and then the messenger RNA goes into the outside the nucleus into the cytoplasm of the cell, and it gets transcribed into proteins. And that's sort of what makes the cells go. You can have mutations in those genes, or pathogenic variant is the term we use now mostly, but mutation is still commonly used. They generally cause, if they're going to get a mutation or a pathogenic variant, they cause loss of protein function. This could be cystic fibrosis gene, could be BRCA1 cancer gene. That gene sort of regulates DNA repair, and when you get a mutation in one of the two genes that you have in each cell, and you've lost 50% of your redundancy to protect the DNA of the cell. And so that's why if you have a mutation in BRCA1, you're much higher risk of developing a breast cancer, ovarian cancer, pancreatic cancer, and melanoma. Muscular dystrophies are mutations in genes. A lot of stuff in the blood, because we're ultimately getting to MRD or circulating tumor DNA. So now we're going on to blood. And there's, back in the day, I never really realized how much stuff was in the blood. We look at red blood cells, they don't have any nuclei. They send the oxygen, they carry the oxygen to the tissues. Then you have white blood cells, and you got a bunch of different kind of white blood cells, but they basically help you fight infection. And then there's all sorts of other things in the blood. Um, if you look on the right side, there are all sorts of proteins, there's nutrients, glucose is carried, all the amino acids, there's salts, sodium, potassium. You certainly have heard of potassium, chloride, CO2, metabolites from cell metabolism, enzymes, hormones, thyroid hormone, estrogen, testosterone. You can measure all of these things. You've heard of lipids, right? Everybody knows their LDL and HDL levels. There's antibodies in there, clotting proteins, and you can even measure drugs and alcohol in your blood. So there's a lot of things that go on in the blood besides just the red and white blood cells and the platelets that help you clot. So there are cellular elements in the blood. And when normal tissues break down, their DNA goes into the blood, their RNA goes into the blood, the proteins from those cells go into the blood. And if you look on the right, the blue and green cells are normal cells. They're growing, they're dying. That stuff gets recycled, and it gets recycled by going into the blood and going where it's needed. But if you have a tumor, if you have a cancer, the tumor cells also grow, divide, die. Generally, it's a cancer because they're growing sort of unregulated, but cells are dying. Their products of cell death go into the blood also. But you can also have whole circulating tumor cells. That was a field for a while, maybe 20 years ago, where we were trying to measure those. Some people are still trying to measure it, but I think we've gone beyond that now. Tumors can secrete proteins into the blood. You may have heard of CEA or CA125. Those are tumor markers. They're proteins secreted by the tumors themselves into the blood. And then why we're here today is when cells die, their DNA gets put into the blood also. And that's circulating tumor DNA, pieces of the tumor DNA, or minimal residual disease, or MRD. So how do you detect circulating tumor DNA when there's a bunch of normal DNA in the blood? And there's really two main broad categories to do it. And you can detect the circulating tumor DNA with using the patient's own tumor. I'll tell you about that in just a minute. And what you're looking for are these single nucleotide variants that are specific for the tumor, or they could be small insertions or deletions, rearrangements of small segments of the DNA. And you can find those changes in the blood, and they're indicative of the patient's tumor. Or you can have large-scale rearrangements, structural variants too. That's another methodology of using the patient's tumor to find circulating tumor DNA. So these minor variants or these structural variants, they're typically in non-coding regions. They're very stable. They are often, the assays typically use between 16 and 60 of these DNA fragments. The fragments themselves are around 150 base pairs. Remember, we have 3.1 billion 6.2 billion in each nucleus. So these are tiny, small fractions of that amount of DNA base pairs. Or these base pairs, or you can look for large rearrangements. They're very sensitive at tracking tumor-specific DNA variants in the blood. So how do you do it? So you take the patient's tumor and you look at all of the genes, look at all the DNA of that tumor. You sequence their entire genome, 3.2 or 6.2, 3.1 or 6.2 billion base pairs of that tumor. And then you take the normal white blood cells that are in the blood that are not cancer. Those are the normal DNA. We'll call it normal DNA. And you do a complete sequencing of that. And then you compare the two sequences. and you see what's different between the tumor DNA sequence and the normal, the white blood cell DNA. And you're going to identify thousands, maybe, certainly multiple differences between those two. And then you're going to select out those differences between the tumor and the normal, and you're going to make a custom assay of that patient's tumor-specific DNA. Think of it as a tumor fingerprint in the blood of that patient. Haystack does it, as you can see right there, our sponsor today. But there's a bunch of companies that do it. I should have put my disclosure slide up. I don't have any disclosures for any companies, but there's a lot. Those are just a few of the companies. There's even more companies that do it than that, but those are kind of the main ones that are out there right now. There's another way to do it without using the patient's tumor. Well, how in the world does that occur? Well, how you can do that is there are sort of tumor DNA changes in a lot of tumors that are common among a lot of tumors. And so you can use those DNA tumors, those DNA changes from a lot of different tumors as a off-the-shelf test. And you use that in combination with methylation changes of the DNA. I don't want to go into that chemistry and that science, but there's more methylation of the DNA of tumors than there are of normal DNA. So you can use that differential to figure out if it's tumor DNA or if it's the patient's normal DNA. So these are sensitive markers, even when there are not a lot of mutations in the tumor itself. These are tumor agnostic. So you take the DNA that are common to many different cancers and the methylation, and that will improve the sensitivity. The current assays that do not use the patient's tumor are right now are not as sensitive as tumor-informed assays. Here's how you do it. These are tumor agnostic, meaning you do not have to have a biopsy. You don't have to have a piece of that tumor to make this test. These are off-the-shelf assays. They use that DNA methylation that I told you about, on methylation of tumor DNA, and a fixed panel of known gene mutations. And then you make an assay. There is a little bonus for this, though, in that the gene mutations they use, if they find those, some of those gene mutations are actually actionable. Meaning, if you find one of these mutations that has a drug target, then you can use that drug target for that tumor, even if it's not FDA approved for that tumor. If that makes sense, because a lot of these gene mutations go across many different cancers. The way FDA approves things is typically in a organ-specific cancer, but you can have the same mutation in a different organ. You can have, an ovarian cancer approved drug that is present in a renal cell cancer that's not FDA approved, but it's the same mutation. So you can use that drug in ovarian cancer for the renal cell cancer. It's the same mutation. They're actionable that way, if that makes sense. I hope it does. Here are the companies. There's others, but these are the three big companies that make these tumor agnostic assays, the non-tumor informed. I'm just going to compare and contrast the two. Again, on the left side, you're looking at tumor informed assay, the assay that's made from the patient's tumor. You got to have the tumor, because if you don't have the tumor, you can't make the assay. On the right side, it's tumor agnostic. You do not have to have a piece of that tumor, that patient's tumor, to have an assay to develop to have a test for that patient. It does require adequate tissue. It doesn't come up that often in melanoma, but it does come up often in lung cancer, where you're often doing just a fine needle biopsy, a small biopsy of the lung, because you don't want to puncture the lung, collapse the lung. They're often compromised lung patients anyway. So not uncommon for lung cancer patients not to be able to make a tumor-informed assay. You don't need that on the right. Again, these are tumor agnostic. You do not have to have tissue for it. Turnaround time is a little bit longer for the very first test in a tumor-informed assay. But after that, once they make the assay, once they make that fingerprint, then you're fine. It's every 2 weeks, and the turnaround time, that's TAT. Turnaround time is 2 weeks for every subsequent test on the left, and for the tumor agnostic, it's about 2 weeks. And really, this is kind of the real point is right now the sensitive assays are the tumor-informed assays. The tumor agnostic are not currently as sensitive. They're working on that, but we're not there yet. So when do you use ctDNA or MRD? I'm gonna use those interchangeably in patients with melanoma. And you're not going to use it in a screening. Think about the melanoma. Most of the time you can see it on the skin, right? Pancreatic cancer, you can't. So they actually are trying to develop screening blood tests using circulating tumor DNA, tumor agnostic, to try to screen for things like pancreatic cancer or ovarian cancer or other cancers. But anyway, doesn't work, and we don't need that in melanoma. So really the first place we use it is looking at responses to neoadjuvant therapy. And here's a study. It's a small study. And if you look on the left, there's pretreatment circulating tumor DNA. If it's present, and then you look below the orange bar, and it goes away after surgery, after they get their neoadjuvant therapy and surgery, and it goes to 0, then those patients don't recur. If it's present before treatment and it does not go away after you've given them neoadjuvant treatment and surgery, it's still there, all those patients recur clinically. The melanoma is still in their body. Then if you look over to the next column, if you do not see pretreatment ctDNA and it still isn't present after surgery, some of those recur. Why is that? I think this is an assay problem. I think this was done with really the Gen 1 of the tumor-informed assays. They're actually Generation 2 are much better, way more sensitive now, including the Haystack product. But all the new assays are coming out are way more sensitive. This study was done really with the less sensitive assay. But let's say your pretreatment is negative and it turns positive after neoadjuvant treatment and surgery, all those patients recur. So having ctDNA after you've given them neoadjuvant treatment and surgery, and if ctDNA is present, you're going to recur. So you can also use it in detecting minimal residual disease after surgery, and you can use that in kind of in 2 different ways. You can use it as a prognostic factor, meaning after these are patients going straight to surgery, let's say, and you do a circulating tumor DNA on those patients. If it's negative, the top line, not many of those patients recur. But if you have ctDNA after surgery, chances are excellent that you are going to recur. So that's a prognostic factor at time point 0, right after surgery. And this is actually where I think it's probably going to make its biggest impact. And this is in the need for adjuvant therapy. So let's say you operate on a patient, you do a wide excision, sentinel node biopsy. The sentinel node has a small deposit of melanoma in the sentinel node. And you go, well, they qualify for adjuvant immunotherapy, right? But we know that not all of those patients need it. But at time point 0, when they're going to start treatment, we're not sure who needs it and who doesn't. This may be a way to figure that out. And if you're ctDNA positive after surgery, then you definitely need it. A lot of those, there's not a huge, all these studies are not very big. There's only 3 of the 5 patients that were ctDNA positive after their surgery recurred. They all recurred early. But if you're ctDNA negative, only 1 of them recurred at 12 months. So this may be a way to figure out if you need immunotherapy or not after surgery, when typically you'd be given immunotherapy. And then what about monitoring people over time? This is another, I think, great area that's going to be utilized for melanoma. And this is, again, small study, 20 patients, but everybody had ctDNA, multiple tests over time. 6 of the 20 were ctDNA positive during that follow-up period. The time point 0 is on the left, and they're followed over time. If you turn ctDNA positive, they all recurred clinically, all of them. And it appeared the ctDNA turned positive about 3 to 6 months prior to any clinical recurrence. So you're going to find it earlier. Why is that important? Well, I'm a firm believer that it's easier to treat smaller amounts of disease than bigger amounts of disease. Even though we can treat bigger amounts of disease with immunotherapy, I think most clinicians agree that it's easier to treat smaller volumes. So I think it's better to find it early when it's small and it hasn't shown up on imaging yet or shown up as a lump yet. And then last place it's used really is to monitor response in stage 4 patients that have recurred and they're getting treatment. And if you look at, again, these are small studies, but if your ctDNA during this treatment period is decreasing or it's negative, those patients do extremely well. If you start treating them and it goes down, but then it goes back up, those patients are in trouble. And if it never gets better, if your ctDNA is there and it never goes down or it increases during treatment, those patients all recur and do very poorly. So it's a way to monitor without having to do imaging that says, oh, your tumors are getting bigger. That may be too late. You may want to switch treatment if they're not responding with ctDNA or MRD. If you're not decreasing with whatever treatment they're on, maybe you want to switch it to some other treatment. That's what I would do personally if it was me as a patient. So let me give you a couple of real world examples in my practice. Here's a patient, MT. In 2018, he had a melanoma in his left abdomen. It was, intermediate thickness, 1.25, but it was a Castle 2B. I don't want to get into Castle, but if somebody asks a question, that just shows that the genetics of the melanoma show it to be a little bit more aggressive. Because of the Castle 2B, I got PET scan and brain MRI on him right off the bat. It was negative. Did a wide excision, sentinel node biopsy, negative margins, negative nodes. Scanned him again in 3 months. Scanned him in 2019, all negative, 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 negative. Scanned him in 2020, negative. 21, May scans were negative. 6 months later, PET scan shows positive for multiple lung mets and a left adrenal met. Brain was negative. Did a adrenal core biopsy because it was you're not going to drop a lung if you're biopsying his adrenal gland, and it was positive for melanoma. And with a core, you can do a ctDNA tumor-informed assay with a core biopsy. It's hard to do with a fine needle aspiration, just a fine needle biopsy, but you can do it with a core biopsy. So in January 22, I put a Metaport in him. And was it 22? Yeah, 22, and did a Signatera on him in this case. And there it is. So it's quite high. These are tumor molecules per milliliter, mean tumor molecules per milliliter, and it's almost at 2,500. That's before he started treatment. So then he started on Nivo and ipilimumab every 4 weeks, and then drew some Signataras along the way. And look at that. The second one, so he just started treatment. His second one still had just a little bit of ctDNA, a little bit of MRD, but the third blood draw and every blood draw since then has been negative. And this has been now 3.5 years. He has not recurred clinically at all. So this is a excellent example of a patient that had a great response to immunotherapy and then subsequently has never recurred. So we're still monitoring him. Melanoma is, the further out you get, the better off it is, but I like to follow people forever. So anyway, this is and the other thing is a lot, if you, as we start to monitor people by ctDNA or MRD, and it's negative, I think you can save people a lot of scans. You know, a blood draw is a lot easier when they're in the office, get it back in 2 weeks, and you save them a day out of work and radiation if it's a PET scan or a CT scan, and the inconvenience of getting that done. So I think we're going to be monitoring people way more often with MRD or ctDNA in the future as people become more comfortable with negatives being negative. Here's another patient of mine. In 2022, had a left fifth toe melanoma. Again, intermediate thickness, 1.37 millimeters. I did a left fifth toe amputation, sentinel node biopsy. He had 4 positive sentinel nodes. Okay, that's making me nervous, right? So he's going to be getting immunotherapy. So we got a med-onc consult. Scans were negative, though. His systemic scans were negative. He's got started on Keytruda, pembrolizumab. 23, his scans, he had extensive, now he had 4 positive sentinel nodes. Now he's got extensive pelvic nodal disease. Brain MRI is negative. He had no other disease other than all this nodal disease. He got switched to Nivo and ipilimumab. In 24, he started getting in-transit metastasis of his left foot. So it's not working. He's on therapy and he's getting all this in-transit disease. Still, though, his scans show no visceral metastasis, no brain metastasis. He was BRAF positive, so he got switched to BRAF and MEK inhibitors orally. And then this year in March, he had extensive, so it went from his foot all the way up his leg, all the way to the groin, and he developed brain metastasis. So at the time of the brain metastasis, and now he's now got visceral metastasis, not just local regional in transit disease. I drew a Personalis on him, but Personalis is another company that does ctDNA and MRD. And it's in this scale, it's 5,400 on their scale, so quite high. His MRD showed quite a lot of circulating tumor DNA. He got switched to relatlimab and Nivo. And I thought this was kind of an interesting patient because I drew another Personalis, but if you look at the picture of his in-transit metastasis of his upper thigh, you see this halo effect. Some of the nodules are flattened, and you have this hypopigmentation around some of these. So clearly, some of the metastases are getting destroyed by his immune system. But if you look elsewhere, there are ones that have no halo effect and they're still nodular. So he's having some effect, but others not responding. Some are responding, some are not responding. And his second Personalis showed essentially, slightly increased number of circulating tumor molecules. So tumor DNA molecules. So clearly, clinically, he was a mixed response. And in his blood, he was not responding much at all. And then this is the last patient, very interesting patient. So back in 2019, she came in with a back melanoma, did a wide excision and a sentinel node. Her thickness ended up being 1 millimeter. It was ulcerated, but she had 0 of 2 sentinel nodes that were positive. So did physical exams. It was an ulcerated melanoma. So I did scans on her relatively frequently. 2019, 2020, 2021, they're all negative. I missed 22 scans. I guess I got tired of doing them. In 2023, of ctDNA in her blood. It's not a ton, but it's there. So did some MRIs. She's pregnant, right? And showed lung, bone, and abdominal metastases and possible small brain metastases, a couple of them. Lost the fetus. And then a week after the first Signatera, took her for a Metaport, and then I excised the subcutaneous mass, one of those that you could feel, to be able to make her tumor-informed assay. And then drew her second Signatera. So she's had no treatment. We've had 2 Signateras, and we've made the assay now. And here's what her second blood draw was. No treatment, but she lost the fetus. And so the reason this is interesting, at least it was to me, or is to me still, is that pregnancy is a state of relative immunosuppression, right? The fetus growing in a mother has half her DNA and half the father's DNA. That's like putting in a kidney from the father into the mother. It would be rejected immediately. But pregnancy is a state of relative immunosuppression. And just removing that immunosuppression was enough to drop her ctDNA a little bit. Thought that was kind of interesting. So she went to MD Anderson, got a second opinion down there, everybody decided she needed Nivo and ipilimumab. She got 1 dose in Dallas. She didn't have many side effects with that. She got her second dose down at MD Anderson and developed a high fever for 7 weeks, nausea, vomiting, increased liver function tests. Yeah, not pleasant. Sometimes, particularly IPI, has been my experience that is not a pleasant drug to have. But it can be effective. So in August, so a little month and a half later, fever broke. She still had this question on brain MRI of these 2 sub-centimeter metastases. They decided at Anderson to drop the ipilimumab and just give her Nivo only. And here's some blood tests of the Signatera during this time period. It did go up, so it went down after she lost the fetus. When it went back up, I'm wondering if that is from the immune system killing a lot of the melanoma and then releasing all that DNA into the blood. And I'm wondering if that's kind of why it went up there. But then she continued treatment and ctDNA went down. August, end of that month, she had stereotactic radiosurgery of those 2 brain mets. The tumors she felt were palpably shrinking. She could feel them shrinking. She could feel them before. Now they're shrinking. She's just getting Nivo every 4 weeks. And then a year later in December, her scans are completely clean. They continued, 5 or 6 more months. We still don't have a clear picture on when to stop. Maybe ctDNA can help us in that way, but she got her last treatment in May. And if you look at it, positive, 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 then went to 0, and she's been 0 since then. So another success story of immunotherapy. It's been really a miracle. James Allison at MD Anderson was one of the guys who received a Nobel Prize for immunotherapy for PD-1 and PD-L1 mechanism of tumors cloaking themselves to the immune system, and then the ability to remove that cloaking. So pretty exciting, quite a success story. And so I think without further ado, we actually have her on this Zoom. So Debbie, I think hopefully you're here. Yep. I'll stop sharing.
Thank you so much for a great presentation and for also starting out with the basic science, which really
good. Well, I hope that helped. Hopefully that was helpful.
For sure. Thank you. Yes, next we have our patient, Daione Sanders. Daione was diagnosed with melanoma twice in her 20s. At 27, she received a stage 4 metastatic melanoma diagnosis with brain metastasis and completed a multi-year treatment plan. She currently holds NED status. So outside of her health journey, she oversees growth and partnerships for a national media company, and she lives in Dallas with her husband and their cat, George, and she enjoys an active and healthy lifestyle. Daione, thank you for being with us today.
Yeah, happy to. I can't say enough great things about Dr. Beitsch. Obviously, he's been a massive role in my life and my health journey. So he really kind of gave the overview of, I think, the medical side of it all, but I'm more than happy to just kind of chime in and add a little bit more kind of specifics from, I guess, my perspective of it. When I was 23 and I remember being at a wedding and it was right before my 24th birthday. Actually, the photographer for that wedding had come up, said like, hey, you have a mole on your back, you should really get checked out. She had this huge scar across her neck. And so it was on my back. You never see it. I think at 23, you're quite ignorant to really anything could ever happen to you. So had I guess to a dermatologist. And that's kind of how I ended up in Dr. Beitsch's office. And so we did surgery there. And actually, you did not fall off your scans. I fell off my scans because I remember I had 3 positive scans, and I was like, oh, I don't have to worry about this anymore. So that was definitely on me. Again, I'm still quite young at this time. And then, yeah, it was April 2023, April 2023, when I found out I was pregnant. And then I remember feeling a small, like, marble-esque thing in my arm. Didn't think anything of it, figured it was a cyst of some sort. And then I just started getting a collection of little nodules kind of all over. And I remember I had 3 in my stomach, and I was at a gynecology appointment, and I was like, is this pregnancy related? This is hormones. And she's feeling this, and she's like, this is not pregnancy related. I think you need to get this checked out. So at that point, Dr. Beitsch's office received a very frantic email from me of like, I think something's wrong. I need to come in. And at that point, I had felt one in my lymph nodes. And I knew that was concerning because, 4 years prior, they had taken lymph nodes here. So I knew that was an area that I was like, oh, this probably is not great news. So yeah, I sat in Dr. Beitsch's office. He kind of looked at me as like, I know what this is, but we'll test just to make sure. And then I think it was a Tuesday when I came back and we got the official diagnosis. That Saturday, I was in PET scans. The following Tuesday, I had surgery, and you took that tumor and put the Metaport in. And then we did some more of those testings. I initially received my first treatment from oncology team in Dallas, got second opinion at MD Anderson, and just loved the care there. Dr. Beitsch had great things to say about them as well. My first round of my treatment plan was 4 rounds of Ipi-Nivo 3 weeks apart, and then Nivo 4 weeks thereafter for 25 cycles. My first treatment went off really well. I had really, really minimal side effects. I was like, great, this is going to be easy, not a problem. They had given me some warning that it was pretty brutal to some people. And I definitely realized that on my second treatment. I had a fever of 104, and I called MDA and I was like, is this okay? They said, you need to go to ER, get a full blood panel. They said, don't take anything. Don't let them give you anything either. So I was at Presbyterian in Dallas and sitting in ER, and they were like, you're very healthy aside from the obvious. And so the MDA team just said, you got to ride it out. And they said, sometimes we do see the more severe the reaction, the better the results. So I had a very high fever for 7 weeks straight. I couldn't make saliva, so eating food was very difficult. I ended up having 1 week where I was violently ill. And then I developed mouth sores from it. And I think in the span of like 2 weeks, I ended up dropping over 10 pounds. And it was definitely the most difficult time period of the entire 2.5-year journey. And I was quite worried. I was like, my resting heart rate at night was 95. I don't think I had gone weeks without a lower heart rate. So I remember at one point I had asked the team at MDA, could I take an Advil, or is this okay? Am I gonna have a heart attack? And they had really asked me to be quite clean with not putting anything else in my body. So they did say I could take half an Advil, and I did. And I woke up in the middle of the night with hypothermia because my body just could not regulate itself. So it was pretty intense. Because my liver enzymes had also gotten so high, I ended up having to be put on a steroid. And so that also paused my treatment plan until my liver had come down. So eventually, sometime, I think it was in August, so I started treatment, I think it was June, and then end of August, I was able to resume treatment. So I really only received 2 cycles of the Ipi-Nivo combo I was initially intended to, and I did not receive the Ipi thereafter. So I just resumed Nivo every 4 weeks. But then, yeah, I had 2 small brain metastases, and they said, it's kind of on the line of whether or not we radiate. So it's your preference. And I'm definitely in the camp of, given what I had kind of gone through, especially in 2019, to be overly cautious. So we did end up radiating those. And then just subsequently, I was able to kind of The ones that were up in my collarbone, they were shrinking away. The largest tumor I had had, and it was, I think, predominantly in my lungs, but it really was everywhere. But I had a very, very large tumor at the back of my leg that at one point had gotten so large, it actually was limping. I couldn't properly walk. So it was fascinating to actually be able to feel things get smaller. And so that was a nice mental benchmark that it was working. Of course, there did come a time where I could feel no more tumors. And then that was actually really freaky because you're looking for them to validate that it's working. But all in all, it was really good. And so honestly, after April, September of 2023, my treatment plan got really simple because life got back to normal. My fever broke. And then I was seeing my MDA team, but then I was also seeing Dr. Beitsch, which is right down the street. I think it was every 3 or 6 months, just to stay really consistent on the blood testing, making sure. So I was getting the scans, but I also have to fight insurance every single time I get a scan because I'm probably one of their more expensive customers. And so the blood tests have been a really key element for me, just kind of getting that validation that my body is healthy and on track. And I definitely took an approach of control what you can control. So I tried to not make life harder for the doctors and tried to be really good with my lifestyle, diet and vitamins and all that good stuff. But yeah, that's kind of my side of it all as well.
Did you find the blood tests reassuring?
Very, very much. I remember in the beginning, James and I being kind of eager for them more frequently because you can't get the scans with the contrast every other week. It was something that we were doing I think every 3 months. So the scans or the blood tests we were able to get a little bit more frequently. And that was something we definitely, especially at that point in our life, needed some sort of mental reassurance.
Yeah, that's really interesting. I completely understand that. It makes perfect sense. And you were a fantastic responder and fell to 0, which is awesome. But you can also imagine a different patient where it falls and then goes back up. Before scans are positive, I would want to switch treatment, right? If it was me. So I think the future, in particularly in metastatic patients, is going to be following these blood tests. Scans are going to lag behind at least 3 months, maybe 6 months. And so I think the future is really bright for these tests, and they're getting more sensitive. The Haystacks test is now super sensitive, as are several others. But so negatives really are negative, and I'm the future of this is for ctDNA and MRD testing is bright. I think it's the future.
Yeah, and it's definitely something I won't be missing my appointments for sure.
Well, yeah, sure. Yeah.
Because now I know the importance of it, and how limited scans can be in providing that information.
All right, Debbie, do you have questions? I bet you do.
Yes, thank you, Daione, for sharing your story, and I'm so happy that you're doing well today.
Yeah.
We have a lot of questions, and so let's just get started. How reliable is MRD testing for melanoma, and can you have a false negative?
So I would say I think they're very reliable now with the generation 2 tests that we have. I think they're super sensitive now. Nothing is perfect, and so but imaging is not perfect. PET scans, CT scans, and those are less accurate, I think, than ctDNA. So that's my opinion of it. It hasn't replaced imaging yet, and you still need, right now, for insurance, you have to get image. Tom, don't go away. I got a question for you.
Try and keep the spotlight on you.
You have to have imaging evidence before you can change things. But I think the future is ctDNA is going to be more accurate. It's going to pick it up sooner, and we're going to be able to change therapies sooner with ctDNA. Now, Tom, what do you think? What do you think the accuracy? That same question. You can certainly have false negatives, but I think the tests are way more sensitive now. What do you tell people? about the sensitivity and false negative of this test.
Yeah, it's getting better. I don't think any of them are at zero, we'll put it that way. But you know, as you point out, I mean, the technology is getting better and better and better. I mean, it's yeah, this field's not going anywhere. I mean, if you think of where it's going to be in 10, 20 years, I mean, it's going to be incredible.
Yeah.
And you know, the assays that are out now, you know, they're pretty amazing at how deep they can go. You know, and then there's differences amongst obviously all the assays. I mean, you know, false positives, the other thing we always worry about. You know, you don't want to give a patient result, you know, especially if they're in like a surveillance window or something, and then
Sure.
you know, have to, you know, deal with a false positive result. So, you know, that's another thing to look out for with these assays. But you know, really, yeah, I think the future is bright, as you say, and you know, especially, you know, as guidelines evolve and, you know, they just become more commonplace. I mean, this is really new technology. I mean, we're talking,
Yeah, for
you
sure.
know, like 5-10 years now, you know, that this technology has really been mainstream, and you know, it's really becoming commonplace in medical oncology, and a lot of surgeons as well are using it routinely now. It's I haven't seen many things catch fire like this in my
Yeah.
life in the molecular diagnostics world.
Completely agree. And you did bring up a good point about false positives. Don't panic when you get a positive. And the first thing I do is tell them, don't panic. And I repeat it typically in 2 months. And if it's still present or going up, then you kind of know your answer. But I've had a blip up and then it go down. So don't panic if you get a positive, and that could be a host of things. To be honest with you, I think we don't know everything about the immune system, and you may blip up and your immune system's suppressed for whatever reason, and then your immune system catches up, it kills it, and it goes back to zero. So, you know, we're still learning a lot about it, but false negatives worry us, false positives worry us, but we see that in imaging all the time, where the imaging is delayed 6 months from when the patient actually recurred. And so I think this is a more sensitive test than most imaging. That's my opinion.
Thank
All right,
you.
there's got to be more questions. Sorry.
You actually answered like 3 other questions. So that was really helpful. Is there a limit to what types of cancer can be tested with MRD, specifically mucosal, acral, and ocular melanoma?
Well, I don't think there's big literature on that. Maybe TJ knows more about that literature, but my impression of it is no. Any cancer that grows and dies sheds into the blood, and you can find their DNA. You can find the circulating tumor DNA. So be it ocular, mucosal, acral, lentiginous, whatever. It's not specific to a tumor type or non-type of tumor. So I don't know, TJ. You may know that literature more than I do.
Yeah, I mean, yeah, to your point, I mean, if it's growing and dying, has mutations, that's really the key.
Yeah.
But you know, there's some you know, brain tumors, for instance, can be a little bit more challenging because you have to deal with the blood-brain barrier. You know, there's some tumors that you know, like some childhood tumors in particular, like teratomas and things that might be actually just normal tissue. It's just in the wrong place in your body. It's like a tooth that's in the completely wrong spot in your body. Those don't have sometimes a lot of mutations. So if you can't find mutations, you can't make the kind of panels that we were talking about. Yeah.
But I think we'll overcome that also.
Mm-hmm.
And I mean, we talk about the blood-brain barrier all the time. It's generally deranged if the tumors are in the blood.
Mm-hmm.
I mean, so I mean, we talk about blood-brain barrier like it's an impenetrable thing, but
Mm-hmm.
I think that the current my reading of the literature with I'll call them Gen 2 assays that are way more sensitive. I think they can find these brain tumors also. So we'll see. I think we're getting better. The technology is evolving.
Yeah, just getting better.
Yeah.
How widely available is this testing? And also, a patient asked, how do you deal with doctors who might push back on this kind of testing and don't see the value in it?
Fantastic question. It's widely available, but it's almost a belief system. Some people believe in it, some people don't, and I get it. So I take care of patients with melanoma and breast cancer, and the breast cancer world, those medical oncologists really are pushing back hard against it. They're going to lose it, that battle, but because this is technology that is accurate, they say they don't know how to deal with a positive result. Well, they should, and they will. But yeah, some doctors push back about it pretty hard, pretty strongly. You know, what I never get offended if a patient wants a second opinion anywhere. So if somebody has a physician that's won't do it, they shouldn't be offended by going to talk to another physician to see if they'll do it. So you know, I'm not encouraging them to move away from their physicians, but I think it's a discussion they should have with their doctors. This technology is not going away, and it's only getting better. And doctors that utilize this technology will replace the doctors that don't utilize this technology. How about that? For a soundbite.
Yeah. Is the Haystack ctDNA available to all patients, or are they only available through a clinical trial?
That's a great question. No, we did commercially launch this year. It is also available in Europe as well, and internationally. Yeah, we obviously run clinical trials as well. So it's the only state right now we don't. We're still working towards you know, New York State, but outside of that, any state in the U.S. is fine.
If you are on a targeted therapy, will the test provide false data?
Should be unrelated to that. Now, there is, if you're using a tumor agnostic, and that target that you're getting treated with happens to be how they're monitoring your ctDNA in your blood, then I guess the theoretical risk is it could be a false negative, because it's knocked out those cells. But I think the future is tumor informed assays like Haystack and Signatera and Personalis and the other ones. So I think that's a rare event. I love targeted therapy. Targeted therapy is awesome.
We usually end at 8, but if you guys don't mind, we can go.
No, let's go.
In just a few more minutes.
Yeah,
We
it's
do
okay.
have a lot of questions. Okay, great, thanks. Not too long, but we'll try to get through some. How is the flow cytometry currently being leveraged to detect MRD in melanoma, and what are the limitations compared to NGS or ctDNA approaches?
Great, interesting question. Yeah, so that refers back to that circulating tumor cells, the whole cell of the melanoma. Now, I didn't do any research in circulating melanoma cells, but I've done 25 years ago. I did some in circulating breast cancer whole cells. That technology is finicky. It is not as reliable or reproducible as ctDNA technology. So, to be honest with you, I think circulating tumor cells, circulating melanoma cells, meaning flow cytometry analysis of those, finding those cells, I don't think that's not the future. I don't. TJ, what do you?
Yeah, I mean, I'm seeing a heavy uptake of flow cytometry is more in like leukemia, you know, where the blood is the tumor. Yeah, right.
Not solid tumors. Yeah.
Right. Solid tumors, you know, largely the field's moved to circulating tumor DNA. It's very stable, as you point out.
Yeah.
We're getting a lot of questions. 2 questions. 1, is this FDA approved? And 2, is it covered by insurance? We're getting a lot of questions about.
Yeah, those are great questions. It's not FDA approved that I know of. TJ can answer that. Almost all tests in this space of genomics are not FDA approved.
Yeah,
Essentially, all of them.
Yeah, they're called laboratory developed tests.
Yeah.
I mean, yeah, none of the major tests have FDA approval. You know, not to say that these tests won't have FDA approval. You know, over time, some have breakthrough device designation already with the FDA. So yeah, it just takes time for these kind of things. Usually those are with pharmaceutical partnerships.
Right. This technology has gone so rapidly that the FDA is having a hard time catching up, in my opinion, catching up to it. That doesn't mean this technology is bad or inaccurate or isn't worthwhile. FDA approval is not the end all be all. Things like sentinel node biopsy is not FDA approved, right? It's approved by societies and by the NCCN and things like that. But the FDA doesn't put a stamp of approval on sentinel node biopsy for melanoma, which is standard of care, right? So, and as far as insurance goes, TJ can speak more of that. I think if you're on immunotherapy, I think it's approved. I don't, isn't that right?
Yeah, it just depends. I mean, there's a lot of layers to this, but
Yeah,
if you
so
just if you
depends
look
on
at
your insurance too,
yeah,
I'm
right,
sure.
exactly. So Medicare Advantage, there's a pretty good coverage overall. Commercial coverage is evolving. We'll put it that way. A lot of times for commercial coverage, you need to have very large randomized control trials, prospective NCCN guidelines, these kind of things, and those are all coming along.
Yeah.
I will say, I don't think even before I had started therapy, I had any issues getting mine approved.
Yeah, most
Ooh,
of the
nice.
companies, I'll say too, just for the patients out there, I don't want to make sure this is not a barrier for you because most of the companies have some sort of program that can help you, even if for some reason insurance doesn't cover it.
Okay, just a few more questions. We had a few questions about TIL therapy and if any of the patients had gone to onto TIL therapy and if there was any issues with that.
I have not seen a paper on TIL therapy and ctDNA. So it would not surprise me at all if they're gathering that data in the TIL registries, but I have not seen anything published on that yet. Again, TILs are a way to kill melanoma cells, right? Just like you give immunotherapy and that revs up your T cells to kill the melanoma, or you give BRAF and MEK inhibitors to kill it. And so, however you're destroying the melanoma cells, you should be able to follow the death of the melanoma cells with ctDNA in the blood. So, I haven't seen a paper on it, but it's just a different way to destroy melanoma cells. So should work.
Okay, we have about 2 more questions. Okay.
Okay, no problem.
We have a lot more, sorry that we haven't gotten answered, but we can do 2 more. Does there need to be a big tumor load for this to work?
No, it's below imaging detection generally. A big tumor burden will give you higher numbers. Remember the guy with all the in-transit metastases? His levels were 10,000 or something, 5,000. They were very high. And so you will get more ctDNA molecules in the blood the more tumor volume you have. But low tumor volumes can shed tumor and you can find it. That's right now we're working on the lower levels of the sensitivity, trying to make sure that we don't have false negatives.
Okay, and last question, what does MRD testing look like for patients with multiple melanomas?
Yeah, let me clarify, make sure this isn't multiple myeloma, right? Meaning multiple melanoma metastases, then it works fine. It works great for that. Multiple melanomas of the skin, if they've been resected, you're generally, I have not seen this technology ctDNA used with a melanoma on the skin to see if it's in the blood or not, because generally that's just not how melanoma works, right? Often in breast cancer, you'll have a lump. And so you may get a diagnosis, but the lump is still there. In melanoma, if it's on the skin, you often take the whole thing off. So you don't have any melanoma left. So there's no reason to do ctDNA after a skin biopsy, as opposed to in breast cancer where you still have a lump of it there. So that makes sense, I think.
Yeah,
Okay.
I'm going to ask you one more question.
Sure, no
Sorry.
problem.
I think you kind of covered this, but just in case, at what point is MRD testing no longer needed following treatment and remission?
Wow. So that's a philosophic question. And so I'm a bit jaded by my pre-immunotherapy days, where melanomas can lay dormant for decades and reappear when the patient's, let's say the patient's immune system gets suppressed from whatever reason. They get CLL and their whole immune system gets suppressed. Melanoma cells that were sitting around their body can then grow up and become clinically apparent. So now, in the age of really good immunotherapy, where patients, like we've just discussed, go to zero, stay at zero, no evidence, they're off treatment, they have no evidence of disease, they had a lot of disease, now they got no disease. Are there a few melanoma cells that their immune system is keeping in check? I don't know. I don't think I would ever stop doing ctDNA in somebody with stage 4 melanoma. What do you think? Do you want to keep getting the test?
Yeah,
I was going to ask
5 years
Daione,
from
what are
now?
you thinking?
10 years from now?
yeah, I think given the fact that I had it in 2019 and then, had nothing, and the assumption
Yeah,
is
those cells were sitting there for 4
Right.
years, right? Yeah.
so for me, I probably would not ever feel comfortable
Yeah.
getting that again. Just because, yeah, you never know, and your body
Yeah.
goes through different things in life, and so yeah, I would always try to have at least a couple a year.
Yeah, I think TJ, what do you have? Does this come up? This must come up.
Yeah, I mean, I think that these tests should be something that over time you can continue to use. I mean, one tactic the companies like ours use, and I know others try as well, is to find variants that are kind of like at the tree trunk.
Yeah.
Before the branches, so that they don't evolve over time, like if the tumor changes and things, which is inevitably going to happen if it comes back. So but yeah, we don't have studies, to be honest. I mean,
No, we
I
don't.
think,
Yeah. So
it'll be something we'll have to watch over time for sure.
I would say keep going, keep testing.
Mhm.
That would be my.
Anyway,
This has been great.
I think that's great advice. Yes, thank you. Thank you so much. We'll stop here. We do have, I'm so sorry we didn't get through all the questions, but this just shows the importance of this topic. We will do it again. We did an MRD webinar a few months ago, and because it's so popular and we have so many questions, we will definitely do it again. So please continue to send in your questions. With that, I would like to thank all of you for joining us today, and especially thank our sponsor, Haystack MRD, and especially our speakers for presenting today during our Ask the Expert session. We appreciate all that you do for the melanoma community and appreciate you taking additional time to be with us this evening. Again, this program will be available on our YouTube channel in a few weeks, and I will send out an email with that link when it's ready. At the end of the program, when you close your screen, there will be a short evaluation that will pop up on your browser. Please fill that out. It provides us with feedback on today's session and helps us create new programs for the future. It also lets us know that this is an important subject that you'd like to hear more about. Please visit melanoma.org to learn about our upcoming webinars and other educational or advocacy opportunities. And if you have questions that you think of later, please email us at education@melanoma.org. And again, thank you all so much for joining us today.